very much. You guys took all my good questions, so I don't have any left to. We have one more panel left, one by Zoom, and Dr. Kris Paolino will be local presenter. And this is bound to be fascinating. You know Dr. Kris Paolino, and as they set the Zoom up for Dr. Heidi Poots, she's based in Chittenango. For those of you who don't know her, she has a very robust practice in integrative medicine. She's the founder and the physician owner of Integrative Medicine of Central New York, based in Chittenango. You know Dr. Kris Paolino here from his great work at Upstate and from what he's contributed in the past 2 days to this event and what he's contributed over the past several years to the subject of our study at this forum, Lyme and other tick-borne diseases. And they're going to talk about at least 3 different case studies that they have agreed to discuss and talk about their respective, perhaps differential approaches to diagnostics and treatment of these cases. There's Dr. Poots. Good afternoon, doctor.
Hi, Heidi.
Good afternoon.
We see you, and we just, as soon as we can hear you, we will go from there.
I'm unmuted. Can you hear me?
Oh, you're great. We can hear everybody now. And I think it's been given to me simply to do nothing more and nothing less than read the case studies, or at least summarize the lines, and then turn it over to each of the doctors. Case study 1 first.
Hold on 1 second. We have rules of engagement, right?
Yes. Right. And I think in case study 1, we give Dr. Poots 3 minutes to discuss how she would approach the case. We need to go to case study 1, though, please. The slide has to be case 1. And then Dr. Paolino will have 3 minutes to talk about his approach to the same case. And then they'll talk to each other about if there's been differences, how they might approach the, if I got that format down pretty right? Okay, close enough. Case 1, a 15-year-old with a history of ADD, ADHD, an outdoor enthusiast with several known tick bites before 2018. Denies any post-bite prophylaxis to include a deeply embedded tick in May of 2018. About 8 months later, in January of the following year, this case presented with acute deep depression with a lack of focus, cycling to manic behavior every 12 days. He also had new onset severe fatigue, brain fog, speech difficulty, disorientation, poor sleep, tinnitus, headaches, lightheadedness, vertigo, neuropathy, tremors, light sound sensitivity, and, quote, weird sensation. Lyme testing was negative when evaluated by his primary. Testing was later repeated and at that time showed Lyme IgG positivity, 5 out of 10 bands. He was then treated with doxycycline for 7 weeks without improvement, also treated with Abilify and lithium, and then herbal supplements under the Buhner protocol without improvement. A neurology workup was only notable for the benign pineal gland cyst. That's the case. Dr. Poots, how would you or how did you approach this case?
So basically, this is a young man who basically presented with new bipolar disease. And I think that's the important aspect of this case. He had many different systemic symptoms, however, as you see. So the top in the differential really should be that we are dealing with Lyme disease and co-infectors. And the co-infector that mostly has come to mind is Bartonella. I would start, and I did start with standard testing, but looking at things broadly. So in the my training with ILADS, International Lyme and Associated Diseases Society, we look at the cases broadly, and we look at other things that could be affected by tick-borne disease, such as endocrine function. So we looked at his adrenal function, thyroid, testosterone level. We looked at his CBC electrolytes. We looked at his vitamin levels. We looked at his inflammatory markers. And then I looked extensively at co-infectors. So we check, for Bartonella, Babesia, Ehrlichia, Anaplasma. We look for Rocky Mountain spotted fever and tick-borne relapsing fever. But typically in a very difficult case like this, I will do more specialized testing, such as medical diagnostic labs, which is called MDL. And I also use IGeneX because many times these tests are looking for different strains of the organisms. I stopped his Buhner protocol as it was not helping him, and I really addressed his lifestyle, looking at his diet. He was eating a lot of processed foods, so we want people on a low carbohydrate, no added sugar diet. And especially when they're dealing with brain issues, we want them off of gluten. We want to have them do some gentle exercise, just some gentle movement. We always prepare the gut first, so I prepared his gut with probiotics, broad spectrum, including the use of Saccharomyces boulardii to help protect against C. diff colitis, because we're anticipating the use of antibiotics. We always look towards detoxification. It could be something simple as drinking lemon water, going in an Epsom salt bath, but we also use supplements such as N-acetylcysteine or NAC. We also use glutathione, and this can help prepare him for the die-off effect of the organisms. We always look at the biofilm because these organisms are producing biofilm. There's various biofilm agents there. Something simple like organic liquid stevia can actually trigger a significant die-off and get rid of the biofilm. And we also prepare people by using anti-yeast medications. In his case, I use nystatin. And in a situation like this, obviously you always discuss with the patient and his family, should we start with immediate treatment? Should we wait for things to come back on his testing? I started on immediate treatment. This young man was so sick and was literally trembling uncontrollably in my office. So after doing all that groundwork, we prepare him for minocycline. I chose minocycline because it has better blood-brain barrier penetration than doxycycline. He'd been on doxy already. We look at the different forms of Lyme. So it's in the cell wall form, it goes intracellularly, and it also goes into the cystic forms. So I treated him with Plaquenil. I also used cefuroxime, and I had very high suspicion that this patient had Bartonella, so I added rifampin. And certainly if a patient is not responding as well as one would like, we then start going the approach of IV ceftriaxone, whether or not the patient has had a lumbar puncture. In his case, the neurologist refused to do a lumbar puncture on him, but I treated him with ceftriaxone ultimately because he needed that. And then sometimes Bartonella can be resistant to rifampin, so I switched him over then to Bactrim. And you know, the other thing to note here is that when we see bipolar disease flipping on exactly to the day, his parents could tell him exactly day 12, he would flip into mania versus depression. We have to look at parasites. And so part of his regimen also included anti-parasitic.
Okay, Dr. Poots, if I could, I will interrupt you there. Hold your thought, because I want to see how this 15-year-old young man turned out. But first of all, Dr. Paolino, how would you approach such a case?
So it's a little out of my wheelhouse in the sense that he's a 15-year-old. I don't treat anybody below 18 since I'm adult trained, but I have patients who have presented similarly to this with kind of new onset bipolar, delusional disorders, things like that, that have come to me who have tested positive for Lyme disease. I think based on what Dr. Fallon kind of discussed yesterday, this is something that we need to think about. If you had talked to me 6 years ago, I probably would have had a little bit more reluctance to think about Lyme or tick-borne diseases in somebody who's coming with just primarily, you know, some psychiatric issues. But with this patient coming in with all these other somewhat similar symptoms of Lyme, with the fatigue, the speech difficulty, the word finding problems, the cognitive stuff, this is something where I would definitely would have treated, or I would have tested for Lyme. And, you know, it is interesting that the patient had these symptoms for as long as they did and tested negative and then tested positive. So it definitely would make me want to look at alternatives. As Heidi had pointed out, you know, these are the types of patients where I'm going to look at infectious and non-infectious issues. One thing that Heidi didn't mention that I would probably throw out there, in addition, I occasionally will do toxoplasmosis testing and do an IgG, because there is some data out in the literature to indicate that toxo has some psychiatric abnormalities that can occur in patients that have been infected, both immunodeficient and non-immunodeficient patients. So that would be one other thing that I would kind of throw out there in terms of the workup. I oftentimes will do all the same tests that Heidi will do. They don't do a lot of Rocky Mountain spotted fever just because we don't see a ton of it in New York State. It does pop up every once in a while, but it doesn't really fit with my interpretation of the clinical presentation. But I think Lyme would be something that I would hone in on. And I would definitely test for Bartonella because it does have a lot of co-symptoms that I would potentially worry about. I like the idea of using minocycline. I use minocycline quite a bit in patients who have more central nervous systems symptoms. And I always want to try to put somebody on something orally before I go to a PICC line and IV ceftriaxone, just because it's, obviously less invasive. You're going to have less toxicities from the PICC line and the IV ceftriaxone itself. So it's something that I will try first. Some of the other things that Heidi had mentioned are more kind of from her integrative health background. So I generally don't dabble too much into that stuff. Sometimes I will use N-acetylcysteine, but not necessarily upfront like this. I'd want to make sure that I get antimicrobial therapy on board upfront and see if that makes a difference. One of the things that I struggle with, and Heidi has a different approach to this, is I don't like throwing people on a million different things at once, because then I have no idea what's working and I have no idea what I'm treating. So I would normally start with an antimicrobial first, and then maybe try a different antimicrobial, and then maybe some other therapies on top of that. I do think that the one thing that I would point out in any case that comes in where you're suspecting that Lyme has a potential psychiatric component to it is making sure that they've got good mental health treatment, because no matter what, there are cases that, I think Heidi will talk about her outcome here. And there are cases that I've seen where you get antibiotics and people do great and their symptoms go away. I also see a ton more patients where you treat and nothing changes. And you got to make sure you're treating with a mental health aspect and using appropriate medications as necessary.
Okay, Dr. Poots, can you give us a little bit about the outcome with this young man from your treatments?
Yeah, so he did very well once we did all of the oral antibiotics, and then he did need the IV antibiotic. I then got him onto herbals and was able to taper him down off of all of the antibiotics. I worked closely with his psychiatrist. His psychiatrist was able to get him off completely from the Abilify and the lithium. So he was off, and he actually fully recovered. He's working. He's back in school. He's doing all the things he loves to do. So he made basically a recovery from basically like a 30% level of functioning to 100% level of functioning.
Okay. Do you attribute that to everything you threw at him? I mean, because what I wanted you to respond to is the Dr. Paolino's comment that perhaps you gave him a lot of stuff. And some of it worked, but do you know what worked to get him better?
I have to say, as we went through the oral meds, they didn't fully get him better. And that's the reason that I went on to the IV ceftriaxone. And I can tell you that just doing the lifestyle modifications and doing all the steps beforehand, he tolerated therapy extremely well. And that's the key thing. If patients are not prepared properly in terms of their gut and detoxification, that will likely block their ability to get fully better. But no, you can, in many of these cases, you can't tease out exactly what created the biggest push forward. But he did, I mean, literally from 30% to 100% within less than a year. And, these cases are not easy because, it has already affected so many systems, as you see, based on his
right. Sounds like a success, Dr. Paolino.
Yeah, it sounds good. I think the cases that I've seen where I've had success with antibiotics, I've been able to use primarily doxycycline, sometimes minocycline when I've had some struggles with it. I've had maybe one or two cases where I've had to go to the IV ceftriaxone. And unfortunately, the one case that I had was very similar, although about twice as old as this patient. He did not respond, and he needed some pretty strong psychotherapy to go along with what we had tried. So it is, again, individualized patients. I think everybody's a little different. And I think the approach should be to kind of look at everything and take everything into account.
Yeah. And I want to move on to the next case, because then we'll be able to talk globally about their differing approaches to all three cases, which are already becoming obvious. Case 2, a 44-year-old man with tick exposures and Lyme diagnosis made by serology and a positive IgG and IgM immunoblot after 4 weeks of headaches, low-grade fever, fatigue, and diffuse arthralgias and myalgias. He receives 3 rounds of doxycycline, 2 weeks initially, and then 4 weeks twice. Many of his symptoms do resolve, but he has continued to be fatigued and have brain fog, including poor short-term memory and word-finding issues. Dr. Paolino, I think you get this one first.
Yeah, so this is a pretty common presentation for my clinic. Patients will come in, they've been on a multitude of antibiotics coming in the door, almost always doxycycline, and almost always doxycycline as a sole agent. You know, it's always tough. We've talked about the past day and a half of, you know, active infection, persistent infection versus, you know, where you're diving into this kind of post-treatment Lyme disease syndrome or post-Lyme or long Lyme presentation. You know, patients like this, you know, in the past, you know, back when I was getting out of my fellowship, I probably would have said, oh, you know, that's a lot of antibiotics to have been on, and you haven't really had much of an improvement other than the other stuff. And the fatigue and brain fog might be a persistent, more post-infectious syndrome. I have kind of changed my approach a little bit over the past couple of years, where instead of thinking, well, maybe we need to try some non-antibiotic approaches, I'll take another look at their C6 or more recently their modified two-tier test assays and see kind of if those are positive still. I used the C6 quite a bit when Oxford Immunotech had it out and available. It has some nice data to show that with successful treatment, you actually have a drop in the C6 over time. It's maybe not a universal finding, but it helped kind of guide my therapy a little bit, especially if I have a baseline and followed up with a follow-up over time. So I might do an assay and get a quantitative titer. Not really sure what it means at this point because it's not really validated beyond the cutoff. But if somebody does still have quite a high titer, well over 1.1, maybe around the 2 to 3 range, I'll probably give them another round of antibiotics. Now, I am not a fan of doing the same thing over and over and over again, right? So if you have somebody who's been on doxycycline multiple times, I usually switch it up. And we talked a little bit about the bacteriostatic characteristics of doxycycline. So I usually will go to a beta-lactam. It's usually up in the air between amoxicillin and cefuroxime. I think there's pros and cons to both. I feel like amoxicillin has a better bioavailability, whereas it also has a 3-time-a-day regimen where it makes it harder for people to take it. So I'll usually try something like that. And if they respond to that, I might give a round of IV ceftriaxone in a case like this. But what I found is, you know, many patients won't respond. And then I'm stuck with somebody who's persistent brain fog and fatigue. And this is where I think using things that Dr. Fallon had kind of highlighted, not just in his talk more recently yesterday, but also at our summit last year, I use a lot of Wellbutrin. And for whatever reason, it makes a huge difference in some of my patients with chronic fatigue, brain fog. And that also has the benefit of being an anti-anxiety, antidepressive medication. So I have a large number of patients now who have had some benefit from that.
All right, Dr. Poots, this case is yours now. What do you make of it? What would you do?
Well, I think in this situation, one can think that, you know, this may be chronic persistent Lyme disease. This may have had underlying other organisms that sometimes what I find is as I treat the Lyme, these other organisms are more permissible to grow. So there's other issues going on. I always take a deep dive and look at other issues, vitamin deficiencies. I see a lot of B vitamin imbalances, a lot of vitamin D issues going on. Sometimes I get input from a neurologist just to make sure there's not something, you know, that this person is perhaps genetically predisposed to. I also look for toxin exposure. What I have found is that many times when patients have mold toxicity, and we test for mold toxicity in our office, that can mimic the effects of Lyme and actually can block people from fully getting better from Lyme. So in a person like this, I absolutely would do mold, you know, question about their exposure. I would usually use something like IV or oral glutathione to help release, you know, any mold toxins from the body and be able to measure it in the urine. We do something called a real-time urine test. Again, I always look at their lifestyle. Are they eating gluten? I've had many patients where I simply remove gluten. And when you remove gluten, at least temporarily for a few months, sometimes even a few weeks, they do exceptionally better. And I will do things to help strengthen their gut, such as probiotics, because of that very strong gut-brain connection. And many times when you actually end up fixing the gut, you're fixing the brain. In certain cases, depending on how severe, I may get some brain imaging. I've also had some patients that have had COVID, and the bigger problem actually is COVID causing this residual brain fog, issue going on. If a person's really not getting better, looking at all of that net of things that we talked about, I will treat them with a broader antibiotic approach, using, again, something for the cyst and round body forms. These are those more persistent organisms. It can be tindazole, it can be flagell that we use. If it's parasites we're dealing with, flagell also will kill many of those parasites. I also, in our office, we have neurofeedback, and neurofeedback has been quite successful in helping patients regain memory and undoing a lot of that brain fog. I've actually seen patients get better with pain control, which was kind of surprising with neurofeedback. And we also use herbal. So many times, if patients say, I've had enough with the antibiotics, what else can you offer? We will use things like, for example, Japanese knotweed or grapefruit seed extract, and that can go a long way. There's lion's mane mushroom that is very supportive to the brain and to the nervous system. And the key is always to see each patient as an individual.
Yes, thank you, Dr. Poots. We'll move on to case 3, but only Kris, if you want to come back on this one at all.
I was just gonna, Heidi pointed out, looking at other things, I think the main thing that you want to think about when you have persistent symptoms, which I completely brushed over, was the co-infections, right? So I don't generally, in a situation like this, test for anaplasmosis or ehrlichiosis or any of the rickettsial diseases, because you're dealing with somebody who's been on 8 weeks of doxycycline. Generally speaking, if you have anaplasma, it's not going to be something that's going to recur, other than, I think there's been one case of ehrlichia in a leukemic patient that recurred long after the treatment. But for the most part, the tetracycline class antibiotics are great. Like, it is like magic how quickly these patients will respond, and fevers and symptoms will just melt away. I think the thing that I would definitely check in a situation like this would be like Babesia testing. I generally don't trust Babesia serologies because, again, it's a serology. I oftentimes will do Babesia PCR and or a blood smear, but the PCR is really the one I go with.
Dr. Poots, any final word on case 2 before we move on to case 3?
No, I think I agree. I have seen Babesia as well. I always look more broadly at co-infectors. I have seen a lot of things that have come up on that has made an impact. But like I said, every case is unique, so you do need to take that into account. And just, it's a pattern of working with the patient and meeting them where they're at and seeing what's acceptable to them, and also what they can afford, because obviously some of these tests do cost additional money and are not covered by insurance.
Yes, yes. Case 3, 68-year-old woman who enjoys gardening and taking her granddaughter apple picking in the fall. She gets seen for multi-system symptoms, including fatigue, headache, joint and muscle pains, poor sleep, increased anxiety and depression, neuropathy in the feet, abdominal pain, nausea without vomiting, chest discomfort, reports of intermittent rashes, lightheadedness, and dizziness. She has no known tick bites or rash and uses DEET when outdoors and is meticulous about her tick checks after being outdoors, and yet she's ill. Kris, do you want to go with this one first?
Yeah.
Okay.
I think I put this case together and I'm looking at it now. I'm like, oh dear God, what did I do? So this is not an uncommon presentation in our clinic. We have people that are referred to us for a very similar kind of presentation. And when you have this multi-system type presentation, obviously Lyme is a possibility. And you've probably heard, I'm probably going to see people nodding, people have referred to Lyme as the great mimicker, right? So all that means to me is that Lyme also looks like a lot of other stuff. So this is somebody who's going to get like the proverbial $1 million workup. They're going to have everything under the sun, both infectious and non-infectious. I'm going to do, like Heidi had mentioned in the first case, I'm going to look at endocrinology type scenarios. I'm going to look at hypo and hyperthyroidism. I'm going to look for cortisol abnormalities. I'm going to do my tick-borne testing. I'm going to look at Lyme just because she does spend a lot of time outdoors. DEET is not perfect. Tick checks are not perfect. So she definitely has exposures. She's got a lot of other symptoms that are there. So, I might do like a celiac panel just to see if there is a gluten problem. I'm going to do just the routine inflammatory disorders. She's got this kind of multi-system thing going on. She's got the joint and muscle pains. You always think about autoimmunity and rheumatologic disorders. The rheumatologists here have a really nice rheumatic panel that I'm not supposed to order, but I order all the time anyway, because it's very complete and it has things beyond the typical ANA, rheumatoid factors, CCP antibodies. So I'll take a look at those things. A lot of times when I see a multi-system presentation like this, I'll do a serum ACE level to rule out things like sarcoidosis. And then other infections, right? So you got somebody who's got a variety of different symptoms going on. I'll take a look at, sometimes endemic molds like histoplasmosis or blastomyces that are in our area. I'll definitely ask about travel history to make sure that there's nothing unusual they could have picked up overseas. And I'll ask about where they've lived in the United States, because if there's something where they may have lived elsewhere in the US that they may have picked, that would be helpful. And again, I think, nutritional things like Heidi had mentioned, B12 and folate levels are probably two of the things that I'll order often, as well as vitamin 6, especially when I see things like neuropathy. But yeah, this is a complicated case, and this is going to be somebody I'm going to see repeatedly and follow up to try to come up with an answer.
Dr. Poots, this woman is your patient now.
Yeah, unfortunately, I see a lot of, patients with this, and I would say the majority of my patients in a situation like this do not recall having a tick bite. But I always tell my patients that doesn't mean anything to me. They don't have to recognize a tick bite. One could get bitten by a tick and certainly not recognize it. So one has to think broadly. Again, we're always going to test broadly, and I do that, because there will be things that I find that maybe aren't super high on my list, but turn out to be a problem. Vitamin deficiencies, we talked about autoimmune diseases, thyroid diseases. I see a lot of adrenal problems, either when they've been dealing with it for a short term. I see where the cortisol is overactive. Many times we'll do what's called a ZRT saliva test that actually I feel really complements the blood tests well. And I'm able to identify if a person is either their adrenals are too active or sometimes just exhausted and they need some adrenal support. And I have patients that I see in a situation like this where some want to do a lot, some want to do a little, but that's always part of this is to take that into account. One thing I always like to test for, but I unfortunately really can't in New York State, is for other toxins like pesticides. She's obviously been exposed to, apple picking. There's always pesticides involved here, but, petroleums, other chemicals that are in our environment. We think about heavy metals, other things that can, tip a person over, right? And sometimes we see many different things coming together. It's not just one thing. And I think this is a situation we would think about that. I definitely would ask her about mold exposure. I would test her for mold if she is willing to do that. I would, try to strengthen her gut. Sometimes I even do a GIFX test, which is by Genova Labs, looking at the, actual microbial balance in the gut, seeing if they're malabsorbing nutrients and so forth. I think that would be vital to do. And then if she's not, once we do the testing, I definitely would test for tick-borne disease, including co-infectors. Then I kind of, question the patient, how much do you want to do in this situation? And sometimes we just do some herbals just to help her with symptom management in the meantime, while we're trying to figure things out. So for example, curcumin and boswellia can really help a lot when people are having joint symptoms. I'll use low-dose naltrexone, which is a really good anti-inflammatory and is good for pain. I use L-theanine for when people are struggling with sleep and with anxiety. I will use alpha-lipoic acid when they're dealing with neuropathy. And many times, regardless of the causes, these are already starting to help people feel better. And when they start feeling better, they start to get empowered and they don't lose hope. Because one of the big things I see is a person like this can really lose hope, like her whole life has come crashing down.
Don't mean to interrupt again, but I just did, because we've heard a lot from Doctors Poots and Paolino about how they would approach these cases.
Dan, I'm going to say one other thing.
Oh, yeah. I get back.
So I think one of the things that comes up is, whether or not to treat somebody with something empirically up front, like some of the other cases. This is somebody I probably would not treat with antibiotics up front because we don't really know what's going on. And more often than not, I'll see patients like this that will have something completely different as the cause of their symptoms. Just in the past 4 or 5 years, a lot of these types of patients will come into my office and they'll either be ultimately diagnosed with an autoimmune disease. I've had several lupus cases, rheumatoid arthritis, psoriatic arthritis. I've had vasculitis patients. I've had MS. And then I've had multiple cancers that have been diagnosed with perineoplastic syndromes that present similar to this with this multi-system approach. So, and that's something that Heidi's probably seen well more than I have being an oncologist. I think these are difficult cases, and I think these are things that need to have that kind of close follow-up.
Okay, just to be fair, if you want another 60 seconds on case 3, Dr. Poots, you have it. Otherwise, I'd like to open the floor to questions from our people here, our panelists.
Yeah,
So
no,
anybody.
I fully agree that, in a situation like this, I would have more of a tendency to not rush to treatment. And that's why I mentioned the herbals, because that's usually the route that I go for a situation like this, trying to get people more comfortable with their symptoms and then getting the data and seeing where to go.
Okay, we have an integrative medicine specialist joining us this afternoon, and we've heard about these cases. What questions do you have out here for Doctors Paolino or Poots? Questions, comments, hand up. Oh, from you or Zoom land, Keith? Okay.
One of the questions is, what specific herbal supplements are being used in these cases?
Herbal supplements with success, Heidi, the ones that work best for your patients?
Well, I already mentioned Japanese knotweed and grapefruit seed extract. There a lot of times there are products out there. I'm not mentioning, brands or anything, but they will have a blend of the most active agents for the particular co-infectors or Lyme disease that you're looking to treat. Some are more broad, some are more narrow. Black walnut hull works well, and it also works against parasites. We have red root. There's Lomatium dissectum, there's teasel root, in Babesia artemisinin and Cryptolepis work well. And so it's a very broad scope, and there's different combinations. One time, if a person is very sensitive, I'll start them on a single agent herbal. If people aren't super sensitive, I will try some of those combination blends.
Okay.
Yeah, I think to Heidi's point before, every patient being different, I think, and you probably would agree, Heidi, a lot of people tolerate these things really well and they have some benefit, and a lot of people have no benefit or tolerate them poorly. So it's just something just to keep an eye out as a provider, what's working, what's not.
Questions for our doctors right here?
Preface, I'm not a clinician, but as soon as I saw neuropathy in the feet, it screamed Bartonella to me. I've done a lot of reading about Bartonella cases. All of these symptoms, especially the abdominal symptoms and the neurological symptoms, if the intermittent rashes are actually that stria distensae that's common for Bartonella, this is something I would definitely test for.
Yeah. Yeah, Bartonella is usually, even though I have not seen any definitive evidence that it's a true co-infection because there are so many symptoms that are similar, it's almost always part of the panel that I order. So.
Right over here. She's got your mic.
Is there a website you use to look up these herbals and interactions with the medications that the patients are on? Because the patients we see at the VA are on a plethora of medications, a lot of anticoagulants, and you have to be really careful about what you use with the herbals. So is there a site where you can do like an interaction? Because I use Lexicomp for the medications, but for the herbals, I don't really know where to go.
I defer to Heidi.
Yeah, so I use a lot of natural medicines comprehensive database. Some of these you have to pay for and you have to have a subscription. Hippocrates obviously does drug-drug interactions, but there is actually, amazingly, you can pay an extra fee to have herb-drug interaction profiles, having access to that. So I find those two resources very helpful. There are others, but I find they're adequate for researching the interactions. But that's a very good question.
Who else? Dr. Poots, you've mentioned mold illness more than once in these three cases. Is that becoming a bigger deal? Is there any reason these clinicians should know more about the possibility of screening for mold and mycotoxin illness
Yeah.
beyond the tick-borne diseases?
Yeah, these environmental exposures to mold, wet basements, water leaks, homes, you know, it's a tremendous problem. I think it's something that's just an emerging science, and you know, and it's something that needs to be talked about more. It needs to be people need to be educated on it more. I think it is very pervasive, and it's something that will many times keep people sick. The key thing about this is that some people are more genetically vulnerable to the deleterious effects of mold toxins than others. And there's an HLA-DR pattern you know, that we will test for to see if they're particularly sensitive. So you could have 100 people exposed to the same, let's say, black mold infested office, let's say, and maybe only 2 people really get sick. And it goes to show you the variability amongst, you know, people. Not that mold is good for anybody, but some people just, their livers, they just have a easier time getting rid of those. I also see a correlation between people that are most vulnerable to mold are most vulnerable to the horrible effects of tick-borne disease, as well as having difficulty in properly activating the B vitamins. That I do see a link. And I will say this, as an oncologist, I also see a correlation between those that are most vulnerable to mold and these other illnesses we talked about and cancer. And I have actually had patients come to me, specifically the cases that I'm thinking about are lymphoma, where they say, Doc, you know, I really don't want to do this chemotherapy, you know, but I don't feel well, do what you can. And I end up, you know, doing a pretty in-depth review of their situation and find that they do have parasites and tick-borne disease and mold. I treat those, and I amazingly have had at least 3 patients you know, that have had significant reduction in size of their lymphoma. No chemotherapy.
Thank you. Dr. Paolino, did you want to say anything about mold and mycotoxins?
I think this is probably where Heidi and I diverge most impressively. So when it comes to molds, like obviously we deal with molds and infectious diseases, and there are certain molds that we worry about. I mentioned histoplasmosis, blastomyces, cryptococcus, coccidiomycosis, and the Southwest, as well as things like aspergillus and other molds that we can see, mucormycosis and some of those. When it comes to environmental molds, I'm not an expert in that, so I've reached out to some people who are in the toxin world. But my impression has always been it's more or less a exposure and primarily respiratory symptoms. You may have, like with any kind of inhalational injury or inhalational allergy, you may have an inflammatory response that could be problematic. But if you remove the person from the mold exposure, there is no longer an exposure unless there's something that's developed autoimmunity wise afterwards. I've talked to some of the clinical toxicologists here at Upstate who focus on toxicology and toxin exposures, and they don't ever test for this. They don't think that this is something that is a useful thing to do. They don't think it has any clinical relevance, and the studies that they cited didn't make it seem like it was a benefit to the patients. I do think it's probably something that is still being kind of assessed and is still kind of in its infancy, but I haven't seen any definitive evidence yet that the mold toxicity question is as big of a deal as many people have made it seem to be.
Okay, just wanted to get that out there. Questions, again, from the panel for either, or we might have time for another case. Go to case 4. If you can, please. 80-year-old woman now. Erythema migraine, not the rash, not migraines, but symptoms that are consistent with acute Lyme 9 months ago. She was treated successfully after 2 rounds of antibiotics. The symptoms resolved at that time, and her Lyme serology, a Lyme C6 titer, decreases about over the following 6 months. decreases appropriately. Well, she calls the office, though, concerned that her Lyme was back because of severe diffuse joint pain, similar to the initial Lyme presentation, and extreme fatigue and a new onset cough. And then they repeated the Lyme titers, and they are now stable and low, negative. So what do we make of this 80-year-old woman, Heidi Poots?
You know, I would be most concerned here about a relapse, either some persistent Lyme, but more importantly, I think relapse of Lyme may be triggered by something going on in her lungs. So I think it would be very important, you know, to examine her clinical exam of the lungs, oxygen saturation and chest x-ray, to see if she has an underlying pneumonia. Could this be, you know, COVID on top of Lyme? And what I've seen a lot of times is when people do get COVID, their Lyme disease either doesn't truly get healed or they have relapses. You know, there's other atypical organisms that can happen, such as mycoplasma pneumonia, chlamydia pneumonia affecting the lungs. There could be some, you know, other like, you know, histoplasmosis, all these other things that can happen. You know, if she were in my office, I would be checking things like SPD level in case I could maybe support her with high dose IV vitamin.
Dr. Paolino?
Yeah, so this is a lady I had taken care of back a few years ago. It was actually just before COVID hit, I believe. I like the idea of using mycoplasma as a test. Mycoplasma is notorious for having like an autoimmune phenomenon that can occur afterwards. So that's definitely something that would be on the differential. So as part of her workup, I did some routine stuff. I had repeated the Lyme C6 titers, which had come down from very, very high titers, whatever that meant, to completely undetectable over that period of time. She was found to have kidney function abnormalities that were brand new for her, where her creatinine went up from about 0.8 to about 2.3, I think it was. And then I did get a chest x-ray, as Heidi had alluded to, and it showed that she had some pulmonary nodules that were on there. I had gotten her to the nephrologist just because I was worried if there potentially could be some kind of an autoimmune phenomenon. And I'm sorry Rob couldn't be here because this is right up his alley. The patient ended up having some kind of an immune complex vasculitis that was diagnosed on biopsy. And the type of vasculitis that she ended up having is something that typically presented in 30 to 40-year-olds. And this woman was actually in her 80s. So the only real risk factor she had was that Lyme infection that occurred several months, almost a year prior. And it just kind of goes and it solidified a lot of what I've learned over the past several years in terms of the immune effects of Lyme and the autoimmunity that can occur. And this was right around the same time I had a couple of other cases that developed psoriatic arthritis after having early Lyme disease with erythema migrans, as well as a couple other cases. So, as opposed to case 3, where, there's a lot of other kind of autoimmune diseases that potentially could present this way. This is a scenario where I think the Lyme is triggering that autoimmunity and causing problems, and is something to keep in mind.
Again, that's case 4. I don't know, Dr. Poots, if she wants to come back on that one, or again, we'll scour the floor for any questions for either of these practitioners. Oh, hi, Keith.
Another general question. Can you share your experience on glutathione?
Dr. Poots, you brought glutathione up earlier.
I think she might be having some IT issues.
Okay, she was muted. I don't know. Well, wait, is there any other question there, unless you want to tackle glutathione? Kris, that deals with eliminating mold from your...
That's not something that, it's not my wheelhouse.
Other questions? Yes.
I wonder, because we don't have a way to quantify whether somebody is currently infected, even after treatment, these spirochetes are going into tissue. They're not staying in the bloodstream where they can be quantified. How do we know that this treatment, that things were successfully treated? You could be without symptoms now, but if the spirochetes are there, or it's a co-infection and it shows more symptoms again, that was the original infection. We don't know if we've eliminated this from the body, and it's showing up in some instances in autopsies where live organisms are found in people who have been treated.
So this particular case, the fact that she had gone like 9 months with no symptoms. Oh, okay, yeah. So I think it depends on the scenario, right? So there are definitely patients that I have where I'll treat and their symptoms will come back within a couple of months or so. I have a higher suspicion of recurrence of infection in that situation, just based on the presentation. If somebody starts having symptoms within about 2 weeks to 6 weeks after stopping antibiotics, I start to wonder whether or not there's a persistent infection. And that's where I might change up the antibiotic class, maybe go to the IV ceftriaxone, something like that. If somebody has symptoms that pop up after being fine for months or years, that's where I start to wonder, all right, is there something else going on? Like in this lady, is there a recurrent infection, which is less likely in that scenario, or is there a new infection, right? Because unfortunately, we live in upstate New York, we're always around ticks, and unfortunately, we don't develop a robust immunity in the vast majority of cases of Lyme where we're going to be protected. So I think it depends on how long people have had symptoms. I would really like to use something like the C6 or the VLSE assay to see if we can validate that in a way that could show that, yes, a decrease in the titer is consistent with treatment cure. I think that's something that could be looked at. I've reached out to Zeus Scientific to see if they'd be interested in doing that study, but I don't think we have any other real clear answers other than like, you know, the art of medicine and trying to follow up. So.
Yeah.
Let's bring in Zoom now.
This was a question addressed to Dr. Paolino. Lisa Diglio asks, do you have any nutritional approaches for your patients that are refractory to treatment?
I generally tell people to go low sugar. That's the one thing that seems to be the most beneficial in my patients and seems to make the most difference. I feel like there's enough data that would indicate that, you know, having excess sugar in your diet is more pro-inflammatory. I don't think the dairy-free, gluten-free approach works for everyone. I've had some patients where they had persistent symptoms. They went sugar-free, dairy-free, gluten-free at age 17 and basically had to live their lives without being able to have any joy when it comes to eating anything. And that just made them more miserable. And when we reintroduced things like dairy or reintroduced gluten, they didn't have any change in their symptoms. So I generally tell people to go low sugar. I think the rheumatologists and the people who work within the inflammatory realm of medicine, they may go a little bit more strongly with the dairy. I think gluten makes a lot more sense if you have documented gluten sensitivity or obviously celiac disease. But sugar is the first and foremost thing that I tackle, and I think Heidi's probably similar, maybe a little bit more aggressive with some of that stuff.
Dr. Poot, since we can hear you and see you again, the question was about nutritional remedies.
Yeah, I try to do a low carbohydrate, no added sugar. You know, I try to have people avoid or minimize the dairy, and gluten is the biggest offender. And you know, whether they have celiac or not, I have seen that it helps to eliminate gluten, at least in the part of their journey where they're trying to get better. And then once they're better, then they can reintroduce gluten as long as we're not finding, you know, celiac antibodies. And many people after that can safely go back on gluten. I have, however, had patients that reintroduce gluten and they started noticing they're not feeling as well, their brain fog is coming back. So that way they can actually gauge how much of an impact it has on them. And I should say, I also caution them about drinking any alcohol because it's just added sugar, and the fatigue and the mental fog is exacerbated by alcohol. People usually feel worse. So at least as they're healing, I ask them to refrain from drinking.
That last point is really pertinent. You know, I find that almost all my patients feel worse when they drink any little bit of alcohol. And just from a personal standpoint, I had long COVID symptoms for 5 months with fatigue and a little bit of brain fog. And I have found that even now, if I have more than like 1 glass of wine or something like that, I feel awful. Not the next morning, I feel like hungover that evening. So I think it's something it's important to avoid in patients that are suffering from some of these disorders.
Well, we have to leave it there, but not without a nice round of applause for Dr. Heidi Poots.
You're very
Let her hear
welcome.
it out there in Chittenango. See ya, Dr. Heidi Poots and Dr. Kris Paolino, please, who's right here with us.
Take care.
Thank you, Dr. Poots and Dr. Paolino, for being with us this afternoon.